Greetings, everyone. This is Dr. Dave Donahue. Welcome back to the Health Rules podcast for episode number 4. So, this is the podcast where we build a health-related checklist each episode. We interview a world expert on a particular topic, and together we craft our best attempt at capturing the most important steps that you can follow to prevent a particular disease or to have an optimal outcome in a particular area. We then we take that conversation, we craft the best checklist we can, and we publish it on our website, healthrules.org, on a web page. That web page contains the checklist. It contains a handout version of the checklist that you can post somewhere or give to your letter carrier or your auto mechanic or your mother-in-law or your doctor and have a conversation about that checklist. And we also have this recording published, and we also solicit your feedback. So we try to, and we have references too, scientific references. We try to be as scientific and evidence-based as we possibly can, and we try to, we want to hear from you. We want to hear what we're getting right, what we're getting wrong. So I encourage you to go to the website, healthrules.org, find the page related to this recording, and give us some feedback. Tell me what steps we missed and what we didn't miss. When you're building a checklist, it's inherent that you have to take some approximation of what are the best practices. You can't capture every single consideration. So we try to find the highlights. We try to shoot for about 10 to 15 items in our checklists. So healthrules.org is devoted to evidence-based medicine. We want to find the very best information we can to help ideally address or prevent a particular disease condition. So we borrow from the best that traditional allopathic medicine has to offer, that preventive medicine or lifestyle medicine have to offer, that healthcare delivery science has to offer to tell us what's safe and what's not so safe, and also what we know from sustainability medicine, which holds that the health of our planet and the health of the individual are intertwined. So this week, this particular session, we are going to address the topic of cardiovascular health in women. So our checklist is going to relate to how can we prevent this leading killer, the number one killer among women. And I am delighted that I have a guest, a very special guest. It is not just a lifestyle medicine physician, it is a lifestyle medicine cardiologist. And not just a lifestyle medicine cardiologist. We are going to have the president of the American College of Lifestyle Medicine, Dr. Cate Collings. So Dr. Cate Collings is a very accomplished cardiologist who is absolutely brilliant at what she does, which is preventing all of our chronic conditions, but especially cardiovascular disease. So hopefully you're going to find this conversation as interesting as I did, and hang on to your seats because here we go. All right. Dr. Cate Collings, welcome to the Health Rules podcast.
I'm happy to be here, David.
It is a pleasure to have you here. Could you kindly introduce yourself?
Sure. I'm Cate Collings. I'm a board certified cardiologist and a lifestyle medicine practitioner. My current hat is that I direct lifestyle medicine for El Camino Health in Silicon Valley Medical Development. The prior 25 years I spent as a clinical cardiologist in all facets of cardiology, from outpatient to ICU to imaging, as well as serving as medical director for a cardiopulmonary rehab center in my local system. And then the other hat I wear is as president of the American College of Lifestyle Medicine, so where I know you. And very excited to be part of that organization.
And yes, and you just started in that role, correct?
That's right. I've been part of ACLM in some capacity with the board I don't know if it's 4 years or if it's 6 years. It's a long time, and it's given me as much as I've given it. I mean, I've just been able to immerse myself and be, shoulder to shoulder with the greats in lifestyle medicine, which, obviously has really benefited me. And, I've tried to make a contribution, but it's been an exciting time.
It helps to be one of the greats in lifestyle medicine to
Yeah.
get in those close quarters with the other greats. This is so cool. I'm just gotta know. I'm so curious. Like, how did you come to ACLM? And you're a cardiologist, right? You've been practicing cardiology for how many years?
Oh, 30 years.
Yeah.
Yeah. If you count
How
up my fellowship training and everything. Sure.
Right, right. How on earth did you come to this place where
That's
you were
right.
the president of ACLM?
That's right. It's a fun kind of a circle story, I would say. Um, in my undergraduate years, I was very interested in the physiology of exercise. So the fact that exercise could be so powerful in improving our health. And that was my undergraduate major. And then I went on to graduate school in physiology of exercise. And there, one of the hats I wore was monitoring heart patients as they went through rehabilitation. And so most mornings, whether it was freezing cold in Madison, Wisconsin, or warm and balmy, I was out jogging with patients that in those days did not have stents and bypass. So they were very high risk. They'd had big heart attacks. And, all I was trying to do was make sure I was there in case they had an arrhythmia. But I became really impressed with the power of lifestyle in these people in these individuals. I did research in the cardiovascular, I should say the cardiovascular effects, the maternal fetal effects of cardiovascular exercise in women. That was my master's thesis. And then I went off into the world of medicine, which is disease, and pills and procedures. So at about the time I was doing yet another recertification in cardiology, somehow I came across Lifestyle Medicine Conference, and I said, well, while I'm studying for the boards, I'm going to go see what this lifestyle medicine is all about. And it was I think it was in Laguna Beach, California. So I would study for my boards for about 5 hours, and then I'd go and listen to talks by, lifestyle medicine trailblazers and so forth. And, the light went off that learning more about transplant immunology, and heart failure, while important, we need those things, just wasn't sensible. We really needed to bend the curve at an earlier place. And I just really believed, going back, that we had the capacity to do so much more with lifestyle. I've been completely lost during all of my cardiology training. So it was at that time that I just volunteered to become part of the organization as much to understand it more, to contribute, and to learn. And, once I got my foot in the door, I really realized it was my tribe. This made sense. The other had just got itself, it just worn me down. And I think it also came at a time when I'd followed so many patients and they had more things cropping up that I knew were lifestyle related, and I still wasn't feeling like I was helping them enough. So I really wanted to figure out a way I could help my patients.
Right, right. That's interesting that you portray this juxtaposition between studying for the deep in the weeds of allopathic traditional cardiology at the
Absolutely.
same time that you're at the American College of Lifestyle Medicine conference, learning big picture, how to prevent, hello, our leading killer.
Yeah.
And so I could see how that's a big transformational moment. Fascinating.
Yeah. Yeah.
And so how can, and we want to get to the business of building this checklist, but
Mhm.
before we get there, how can people um, follow you or uh, become a patient at your clinic or Is there a website, a presence?
Yeah. Yeah. So yeah, I'm not yet, and I don't anticipate I will be a social media guru. So you won't find me on a Facebook page or any such thing, but you can find me through lifestyle medicine / elcaminohealth.org, and you'll see the website for the institution where I practice now. And through that, you'll see events and classes and how to, make set up an appointment for consultation, and so forth. Yeah, we're doing a lot of exciting things. I'm very, very passionate about culinary medicine. I think I told you that a few weeks ago.
Yeah, this is like totally novel stuff to a lot of people. Culinary medicine, that's a thing, and
Yeah,
and it is.
it is.
Well, maybe we're gonna go ahead.
Yeah, it's really the art of cooking, with the science of nutrition, and just really learning how to make healthy food. As Dr. Hauser would say, unapologetically delicious. And it's just such a fun way to bring people to the recognition of the power of lifestyle medicine and the power of their choices.
Did you ever think that as a cardiologist, you would eventually be teaching people how to cook?
I didn't, but it is one of my favorite things to do. So I enjoy it. It's kind of the creative side to my life.
Oh my gosh, you've got so many of those. Well, let's start with a checklist. We talked a
Okay.
little bit before we recorded about the topic, and what would be a title that would capture what we're going to talk about? Like,
Well, I think one of the topics that we wanted to talk about was lifestyle as it relates to women and cardiovascular disease. That's an area I've treated a lot of women over the years, and really have a passion in that as well. And we can talk about that.
that's an awesome topic. So we'll tentatively title it "Checklist to Prevent Cardiovascular Disease in Women."
Sure.
Okay. What are the steps? What is, and I guess this is for both people, women who want to avoid heart disease and their loved ones who want them to avoid heart disease, but also for clinicians who want to help their patients avoid heart disease.
Sure.
That's cool. So
Right.
what are the steps? What can we do?
Well, I mean, I think you appreciate that, heart disease doesn't just happen suddenly when we're 50 years old. We know that the pathophysiology starts when people are quite young. And for women, one of the pivotal points in their life is in their perinatal, prenatal, postnatal years. And so we know that things like preeclampsia, hypertension that develops during pregnancy, or even preterm labor, or even small baby size, small low birth weight babies, those all tell us something about women's vascular system, because the placenta is an enormous bed of vessels. And so women that have those untoward events during their perinatal years, this is really a marker of their cardiovascular health later in life. So that's sort of the first tick point. Are women carrying their pregnancies completely normal? They're not preterm. They don't have any, gestational diabetes as well, or gestational hypertension, or preeclampsia, and so forth. So that should tell women a lot about their cardiovascular risk at, a relatively young age, and lead them to take more interest in the checklist, which has to do, with their blood pressure for the next, 10 years, carefully, because many times the blood pressure will come back to normal in the postpartum, or maybe about 3 months. And then, busy with family, busy with young children, all the things that come into people's lives in those years, they can easily take their eye off the fact that their blood pressure may be creeping up. So understanding that. Same thing with gestational diabetes. The women there are at more risk for subsequently having insulin resistance and prediabetes. So having an increased awareness and screening for those conditions are really important in those postpartum years. Another pregnancy comes up and so forth. And it's so easy for women to let go of their own health needs in that period of time because they're focused on their children and maybe their career, and there's a lot to juggle.
Oh yeah, they're postpartum depression. They're trying to make
Absolutely.
ends meet. They're trying to get back to work. You can certainly understand why women who have just had a baby are not focused on that slightly elevated blood pressure or remembering the fact that they had gestational diabetes. But
Yeah.
would you agree that gestational diabetes really kind of is crying out? I mean, it's a very, alarming signal that
Yes.
yeah, because it signifies a lot of bad things to come, right?
Right, right, right. Even when it goes away, it's telling, a lot about what's going on in the inside, over time. And, it's a stress test. Pregnancy can be thought of as a stress test. So it's a stress test for blood pressure. It's a stress test for diabetes and glucose regulation. And so, that stress goes away, everybody sighs and says, hey, we're out of that risk, but we're really not. It really was a stress test. And, we think about stress tests in terms of detecting underlying coronary artery disease when we put people on treadmills. So in many ways, pregnancy is a stress test, a physiological stress
Right,
test of a different type.
right. And the signals are a little more subtle, little different, and you need somebody who's mindful of this to interpret those signals and tell you, look, you're at risk of heart disease, right?
Yep, absolutely. Absolutely. And I think the OB-GYNs are doing a great job of this and better in identifying these women and, oftentimes referring them to cardiologists, early on. So many times the OB-GYNs are women's primary care physicians for a number of years. You probably know that. And then when women are out of their childbearing years, then they start thinking about a family practice doctor or an internist, but sometimes they really rely on that OB gynecologist to shepherd them.
Mhm.
And I think that similarly, oftentimes, elevated lipids are seen in those years as well. I think less of a prognostic feature to subsequent cardiovascular disease, but certainly, something that should be taken into account. And just like hypertension, we know the number of years that somebody experiences high cholesterol and triglyceride levels, the number of years that they experience high blood pressure, are important variables in the progression and development of cardiovascular disease. So those are really important things to follow in those perinatal years.
Awesome. Okay, so it seems like I don't know if this is like an item number one in our checklist, but be mindful of your risk factors. Well, we didn't. I mean, be mindful of the signals that you might have early heart disease developing, cardiovascular disease developing.
Mhm, mhm.
Um, what about? And you mentioned some of the risk factors, that elevated lipids that you have younger in life, the higher blood pressure, family history, right?
Certainly, yeah. Family history.
And we're talking about like a primary relative, a brother, sister, a mother, father, who
Right.
has, and what constitutes a family history of heart disease that's worrisome?
Well, typically it's been, less than 55 years for a male first degree relative and less than 65 for a first degree female relative. You know, I'm not super quantitative about this, David. I kind of always, when I talk to people, I get a gestalt because then I'm like searching for, okay, was your dad a smoker? You know, was your mother X, Y, or Z? And usually when I peel the onion, you start to see, aha, that's kind of a pure family history. That's telling me a whole lot more because their lifestyle, I can sort out their lifestyle. So there's no absolutes in this, but those are sort of the guidelines. But it's good to take to gain more insight into what that first degree relative, how they led their life, and how did they lead their lifestyle, because maybe it was all lifestyle born, and this patient, and I've seen that more times than not, that somebody has this daunting family history, but when I dig around, somebody was a smoker, somebody had a very poor diet,
Right.
any number of those things. And I'm like, we
Maybe.
need to, peek at that, but maybe I'm not as concerned about that family history.
Got it. So we can kind of risk stratify ourselves and understand how much risk we have based on a little bit of that family history, parsing through those details of, is this really all that worrisome? And then looking at our traditional risk factors, which you mentioned the cholesterol, you mentioned the diabetes and blood pressure. Those are the big three, I guess. Do you think?
Mm-hmm. Yes.
Okay.
Tobacco.
And tobacco.
Yeah.
And then watching for those, well, you mentioned one natural form of stress test, which is, pregnancy.
Mm-hmm.
There are other tests we can get too. Do you have an approach to getting some of those other tests, like coronary calcium score or other?
Sure. Yeah. So coronary calcium score is, really coming into its time, so much more than, 10 years ago. So for those of you in the audience that may not know what that is, it's an X-ray test. So it has some, it's a tomography test. It is I think it's a poor man's angiogram, and it basically tells you the volume of coronary artery calcium in the entire coronary distribution. So it's by no means an angiogram where it's talking about how severe a lesion is it 70%, is it 90%? You don't get any of that information. You just get a total calcium score, and you get a little bit about the distribution. Is that calcium all localized in one artery, or is it diffusely through the coronary arteries? And where do you use it? So because it does involve radiation, it's really isn't something that we should recommend for everyone. And it's strictly a screening test, and not a test that one would do in intervals to judge how they were doing. I'm going to do it once a year like a mammogram, or once a year or every 5 years like a colonoscopy. It's really a one-time or maybe two-time kind of test. It takes about 5 to 10 minutes. The actual radiation dose, I can't quote you, but it's a reasonable thing to do. But would I do it for a low risk person? And the answer would be no. So when we use it is typically in people who have higher cholesterol levels or other additional cardiovascular risks, and we're trying to decide, do they have some established disease that we need to be more aggressive with? We might leave them alone in terms of not using procedures, or they might leave them, medications, or they might leave themselves alone and not do lifestyle changes. But if we did a coronary artery score and we found that they had established coronary artery disease, two things can happen. One, it can be motivating for them to say, aha, maybe I don't need to wait, and I shouldn't wait. And for the physician, it also is really a great piece of information, because sometimes physicians don't really know how serious a high cholesterol is for that particular individual. They know in general populations, but for that particular individual. And so that helps the physician risk stratify the individual, and it helps them then really, optimize lifestyle, go full tilt on lifestyle. And if other things are needed after that, then, medications are needed to augment that cholesterol lowering. Well, then there's a particular reason to do that, because the coronary calcium score is high. Now, if it was very high, it is also not an unreasonable thing to then do a stress test, because we know a good percentage of people, maybe up to 30% of people have what we call silent ischemia. And ischemia, of course, is insufficient blood flow to the coronary muscle, to the heart. And they can be just carrying on and not know. And, a mild degree of coronary ischemia on a stress test is not going to be a amplify risk in an enormous amount, but certainly if you had a very high calcium score and then you had a markedly abnormal stress test, it would be a reason to take things a little bit further and look at that angiogram to make sure.
Got it. So, and this is how I've used coronary calcium scans as well. It's the science is pretty good. I certainly understand the arguments that maybe we shouldn't do them as eagerly, but it's motivating for folks because you get a scan and you've got some objective evidence that no, your heart isn't doing that, because people tell themselves these narratives like, oh, my heart's fine and I don't have to worry about it. And I
Right.
can keep doing this and I can keep doing that. Well, here's some evidence that we actually have some damage or accumulating in the arteries around the heart, and it correlates with higher risk. And I usually use the MESA score. I know, is that the right score to use? So I Googled
Yeah.
MESA score, MESA, and then I
Mhm.
fill out the little form and include the coronary score, the Agaston score, and then it spits out a 10-year risk. And it's interesting, it gives you a 10-year risk had you not done the calcium scan. And given this Agaston score, this calcium score, here's what your risk is now.
Yeah. 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 And sometimes people get a great news, which is the calcium score is just 0, right? And that's wonderful news as well.
How
And
reassuring is that when you get a 0?
well, I think the data says that, the overall risk of a cardiovascular event for up to 10 years is pretty low at that point. Does it take, would it tell me, not that the patient should not need to do anything about their cholesterol? Absolutely not, in terms of a lifestyle perspective. But I do think it, gives you the confidence that, hey, let's work on this. Let's get you into something sustainable. This is very positive overall. But it's not a ticket home, it's not, yeah. So.
Okay, that's helpful. Thanks for going deep into the coronary scores. Are there any other testing that you recommend doing? You mentioned a stress test.
Well, sure. I mean, I think a stress test, I would only do a stress test in a patient who had multiple risks, strong family history, maybe a very high coronary calcium score in the absence of symptoms. But generally, the stress test is not needed for asymptomatic people, just on any kind of a routine basis. So, most people are going to tell you when something's wrong, and you're going to get some kind of a hint to go on to do a stress test. So I would be hard pressed to recommend a stress test for every person on any kind of interval. I would use it on a patient by patient basis.
Absolutely. And one thing I've seen is we seem to get a lot of cardiolite. That was at the Sestamibi, the nuclear medicine stress tests, which are
Right.
much more expensive than the alternatives and also carry a lot of radiation, right? Do you think
Right.
we overdo stress tests or the cardiolite?
I do. I do. I think that we overdo that. I've always been more in favor of, if we want to add something to an EKG stress test, is to add the stress echo, to add the echo to that. Because it's, it doesn't involve any radiation. And, I think you get the left ventricular function, you pick up some other things with it. So I think the echo, when we can do it as a stress echo instead of a stress MIBI, it's great.
That's helpful to know. But when as a primary care doc, I see oftentimes we'll refer to a cardiologist, and it seems like that's the tool they're going to pull out of their toolbox is the stress
Right.
test, and we just so it seems like maybe we should be a little more cautious about when we use it, because there's a risk with getting too much testing, right? There's a risk with getting a stress test when it isn't warranted. Would you agree?
Yeah. I think, well, there's no end to the number of, false positives, right? That lead on, take you to an angiogram. So there's so much to be said for the history, right? And as you say, as a primary care physician, many times you feel obligated to send them over to the cardiologist and, to cross every T and dot every I. But when they get to the cardiologist, it's really important that first and foremost, they listen to the history. What's the odds that this is coronary ischemia? What's the odds that this is cardiac pain? And so, using the least amount of testing as possible, gain as much as you can from history, and then select the test that's just going to give you the answer. And if you need to ramp it up and do more advanced testing, that's fine too. But you can gain so much about looking at the likelihood just based on the history. And similarly, sometimes you can get false negative tests. I've had that happen where patients, they sound every bit like they've got angina. And I just know they've got angina. And yet when I do some kind of a test, it's negative. Well, for me, I'm still going to treat them for all the cardiovascular risk, because I know that is angina that they're experiencing. And, this is an interesting thing that I would love to talk about if this is a good time, which is non-occlusive disease in women and angina.
Please do.
So, for years in my practice, I saw women with chest pain, and they had been into the emergency room and, ruled out for a myocardial infarction, right? Sent home. I would say too often, told that this was not related to the heart at all. And then they would come and see me. And I would say, wow, this really sounds like angina. And yeah, you didn't have a heart attack, and that's all great. But for you to walk away and think that there's nothing going on here is really a disservice to you. So a lot of those women would go on to have positive stress tests, but negative angiograms. So they go through a treadmill, they'd have chest pain, they would have EKG changes, sometimes no myocardial perfusion abnormalities, and sometimes no wall motion abnormalities. And then they would go on to have a coronary angiogram, which I think was, entirely appropriate under those circumstances. And they would have clean coronaries.
Right. So
and then they would come back.
I was just going to say the angiogram
is
sort of the gold standard. We're injecting dye into the arteries and taking X-rays of them, and we can see without any question the degree of blockage in arteries, or with much less variability. Right. So, okay.
But remember, you're looking at the exterior of the artery,
right?
And you're not looking at the interior, with rare exceptions. I mean, you can go in and do an intracoronary ultrasound, but generally, if the angiogram looks like this is, an artery that doesn't have blockages, no one wants to put a catheter inside there to, instrument inside the artery, nor do I, because, you can disrupt things in there, you can cause spasm. It's really not appropriate. So the important thing is women leave a lot of times with the fact that, with the understanding that they have clean coronaries, everything's fine. And they're further, now have maybe believed that this is all in their head, that the coronary, the chest pain is in their head. But what we've found over more and more time is that oftentimes these women who really have classic angina, so I'm just talking about, they get angina when they're enormously stressed, they get angina when they exert themselves, they get angina when they go up a hill, and it's relieved with rest. So very classic anginal symptoms. Will have small vessel disease that's throughout their heart. And so it's that homogeneous appearance. They're getting less blood flow throughout their heart. So they do have ischemia on an EKG,
right?
But they don't show it on wall motion because there's no heterogeneity of wall motion. And they don't see it on a perfusion scan because, again, there's no heterogeneity on the perfusion scan. It all looks quote unquote normal. So the worry in that is that they leave risk factors unattended. They leave angina unattended, which I don't think is healthy, you know. And what's also really important is that these women, because this is small vessel, because it's the lining, because it's endothelial, they benefit, I would say, even more than men from lifestyle changes. So when they do things to heal that endothelium, when they become exercisers, you know, in a monitored and progressive way, when they change their diet and, you know, amplify, you know, anti-inflammatory foods and foods that nourish the endothelium, you know, nitrate precursors and things like that, they get, you know, more bang for the buck out of those kinds of things. And equally, when they do stress management techniques that we know can also, you know, we have this amazing brain heart connection, they get even more value out of that. I possibly should be careful about the more, but it's just that we don't see that type of microvascular small vessel disease as often in men. So, so lifestyle becomes even more imperative for women.
Fascinating. So, well, I guess that's an appropriate segue to talk about lifestyle. So, someone who's worried about heart disease, which should be everybody because it's our leading killer, and every woman, because I believe it's leading killer of women.
Yeah.
And so what things can we do not to detect, not to risk stratify, but to actually reduce our risk of complications or of death from heart disease?
Sure, sure. Well, you know, I think it goes back to those, you know, the 6 pillars of lifestyle medicine, you know, that we focus on. You know, with first and foremost is optimizing nutritional lifestyle and eating patterns, and, you know, focusing on plant predominant foods because we know those are where we get the most benefit in terms of anti-inflammatory foods and the polyphenols and the flavonols and all the things. And at the top of the list for those, it seems in cardiovascular diseases, you know, green leafies, dark yellow vegetables, grains, and fruits. And, you know, then of course we know that it's just diversity, and bringing in more and more diverse plant foods. And then in the avoiding the pro-inflammatory foods, you know, the red meat, processed meats, organ meats, and, you know, refined carbohydrates. We see those as being pro-inflammatory for progression, you know, initiation and progression of cardiovascular disease. So diet is, you know, one of the dominant pillars for lifestyle interventions. And I know you share that opinion as well. You know, but I'm just really pro exercise as well. You know, I do find that people drop off in exercise once they have a family. The young children's needs are, you know, paramount. And so they often don't do that piece of self-care. But it's so important in terms of cardiovascular prevention as well as treatment of just, you know, keeping those vessels and the heart as a pump strengthened, and really, you know, facilitating this endothelial function where we're putting increased blood flow through the coronary arteries on a regular basis.
So exercise, I mean, yeah, I mean, I think everybody gets that one, and it's so powerful. I mean, even things like breast cancer, you know, are prevented and respond to exercise in a big, powerful way. And you made a great point that we stop exercising, and especially a lot of the mothers out there who are too busy driving their kids around from event to event, standing on the sidelines or sitting on the sidelines.
Yeah.
While the kid is getting the exercise, and wouldn't it be better if we could find a way we both get exercise at the same time?
Yeah. 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 When my kids were young, it was, those were when they first were coming out with those, what I think they were called in those days, baby joggers, and they had the big wheel on the front. They were a stroller with a big wheel so that you could take them over,
Yes.
dirt roads if you wanted, and so forth. And that was just such an important. I think I got it off of Craigslist or something equivalent, and boy, that was a great way to keep my exercise up when my kids were little. But you're right that it's so important in recovering from pregnancies and in just the self-care that women need to take, in those years, and not wait until the kids are out of school and so forth.
Right, right. Yeah. Exercising straight through a pregnancy and in the postpartum period and on into life. It's one of the most important medicines you can take for certainly for heart health, right?
Yeah.
I love it. That's great. Thank you. So we're walking through our pillars, and we talked about nutrition and focused particularly on anti-inflammatories. And I wanted to ask you, you said leafy greens, that they're rich in all sorts of anti-inflammatory compounds. You mentioned dark yellows.
Yeah, dark yellows. I mean, I can't tell you exactly, David, what that is. I think it's just that a reflection of, eat the colors of the rainbow,
Okay.
in terms of getting all of the variety of antioxidants that we can get when we
Right.
get different colors of vegetables.
Right. Are there other specific foods that you would call out that seem to have heart protective effects?
Well, I think, flaxseed has been an interesting one for me as a sort of a functional food for hypertension. So that's an interesting one to keep in the mix. I think to some degree, a very modest amount of nuts is important, but because of the healthy fats, but we know that processed oils are not the way we want to go, even in even if they are a plant-based oils, obviously, but they're processed and so forth. So whole food fats, but in very I would say minimal amounts in terms of cardiovascular.
Yeah.
Yeah.
Okay, that's cool. And how about sodium? That seems to be really important. If you
Yes.
look at the Global Burden of Disease survey, that like the leading nutritional cause of early death is sodium, excess sodium intake.
Yeah. Yeah. Right. And I think where we find that is in anytime we're doing takeout food, anytime, even if we're saying we're taking out something that's vegetarian in a, from a takeout or going to a restaurant, you can be sure that chef is more concerned about you coming back and will load that up with sodium because that's his or her audience is very interested in that. And then the second thing is just, your ingredients from the grocery store. And a very little part of reducing sodium is what you do actually in the kitchen. Most people are not liberally salting in their cooking. So the minimal amount that they'll use in cooking is usually fine. It's really the stock and the processed foods and the restaurant and takeout foods where people are getting really unforeseen amounts of sodium, that's kind of slipping by them. And
Yeah,
so
great,
important. Yeah.
great point. A lot of people think they're eating healthy, but when you look at the sodium intake, it's still very, very high, right?
Yes. Yeah.
So that's good to know. Home prepared meals is helpful. Circling back again to culinary medicine.
Right. Right.
Okay, great. So we talked about lipids, we talked about anti-inflammatories, we talked about sodium. Is there any other elements of the diet that are particularly important for heart disease?
Right. Did we talk about total fat and cholesterol?
Well, I mean, we talked about, yeah, you want to you keep the total fat down and especially avoid the unhealthy fats, which would be the meat-based or saturated trans fats. And also, yeah, you're right, dietary cholesterol is
Right.
important as well, right?
Right. Right.
Uh,
Yeah.
the more eggs you eat, the sooner you die, and mostly due to cardiovascular causes, right?
Right.
Okay. And so, okay, good. So we kind of covered nutrition, very,
Mhm.
very important for heart disease. Um, Following those fats, by the way, going back to testing,
Mhm.
we want to what? We want to, as women, we want to check our lipid panel once in a while. Are there fancy tests we should be getting?
Right.
C-reactive protein or a good old fashioned lipid panel? What do you suggest?
Well, I think a good, obviously a good place to start is a good old fashioned lipid panel, and looking, at the I'm sorry, looking at the LDL and total cholesterol. Women have, I think, been a little bit misled, since we're on the topic of women and heart disease, with this concept that HDL is so protective that I don't even need to look at these other variables because, oh my goodness, look at this high HDL that I'm carrying around. I think I fell into that a little bit, that data early in my cardiology career, but I soon came to find that there were many women showing up on my doorstep who had these beautifully high HDLs, and lo and behold, they'd had a cardiac event. And, when we go deeper into the HDL story, including if we were to do detailed HDL testing, right, the subtypes, we find that not all HDL is protective. So, what I've kind of come with, rather than doing that detailed HDL testing, is like, I'm going to look first and foremost at LDL. I'm going to pay big attention if the HDL is low. So I know if the HDL is low, this is a cardiovascular risk. What I don't take is the inverse, that if the HDL is high, this patient is not at cardiovascular risk. So, we sometimes see these folks that have pretty low total cholesterol, pretty low LDL, and very low HDL. That's way more concerning to me, that low HDL. And I'm not really reassured by somebody who has a high total, a high HDL, and also a high LDL. And so, I'm still going to primarily look at the LDL and say there's still enormous benefit to you getting that LDL down.
Do you have a target? Because some would argue, some have argued that the what's normal in the lab is actually too high. It's just based on high cholesterol is so rampant in
Yes.
Western society that they just said that's normal, but that's still a level when you have an LDL of 100, you still could get heart disease. You want to get it even lower to have zero risk, right?
Right. Right. And I think that if somebody has no other cardiovascular risks, they're not diabetic, they don't have a family history, they've never been a smoker, and all these variables, and their LDL's around 100. I mean, I usually will say it'd be nicer if it was lower, but I'm probably not going to get as excited. But lower is better. We know that LDL, the LDL level is what correlates most with atheromatous plaque. So lower is always going to be better. And, many of the studies, there was a time, and it wasn't that long ago, that there was concern that you could get someone's LDL too low. And I can remember this when I was using a lot of statin therapy. When I would find patients come back with an LDL 40, I'd be like, well, wait. I don't know that I like that. I don't know what the long-term effects of that very low LDL are. But fortunately, I think most of the data says there's no risk from that lower LDL. When we've seen it, it's usually, when it's correlated with a poor outcome, it's usually because the patient is getting that low LDL because they're sick in some other way, right? And that's the main risk. So I think, lower is better. And certainly we used to use the target in all of our patients with established disease that we wanted the LDL less than 70.
Okay.
So it's not a bad target for all of us.
Good to hear. While on the topic of testing, are there other tests that you follow over time?
Well, in some patients, I'm really trying to take a deeper look. And in women, I think the data for C-reactive protein is a little bit more compelling, that But I'm not as impressed with C-reactive protein as another marker. By and large, I think it's not yet, we don't yet know the best marker for understanding inflammation as it relates to, increasing the risk of cardiovascular disease. I think CRP, cardiovascular protein, is maybe okay for population studies, but I'm not sure it's okay for the individual. I say that because I've seen women that I've done everything for, including even statins, and their CRP is still high. And then I've seen plenty of people where the CRP was just normal. So I don't think it's a great test. And then sometimes, but I still look at it to see if it can tell me anything more. And then there's, a lot of interesting detailed tests on insulin resistance as a risk factor for cardiovascular disease. There's interesting tests on the subfractions of LDL and HDL, LDL particle number. They're all useful, but I don't do those in every patient.
Okay.
Because I just don't think they're necessary and they don't guide me. When I'm equivocating on somebody's risk, then I'll maybe take a little deeper dive and look at some of those things.
Got it. Okay, so nothing else really bubbles to the surface beyond.
Right.
So our lipids, our blood pressure, our hemoglobin A1C
Right.
as a measure of insulin resistance or diabetes state.
Diabetes, yeah.
Okay, and so clearly for heart disease prevention, we want all those to be optimized, right?
Mm-hmm.
Okay. And so we were walking through our pillars. Are any of the other pillars warranted to call out here as particularly protective of the female heart?
Well, I think the stress management piece is a pretty big player in women's lives and their cardiovascular risk. I haven't delved into that research too much recently, but when I did several years ago, it was interesting that stress was a significant factor in the development of cardiac events for women. And we know there's good stress and that makes us thrive and is exciting. And then there's, less good stress. And so for women, it turned out that actually relationship stress was the highest risk for them. Work stress, not so much. And this was an interesting study, and I wish I could quote it, but it's been a long time since I looked at it. But it was done in, I think, in a Finnish country, and looked at women who'd had cardiovascular events. And it really wasn't, they didn't really rate work stress. It wasn't women going into the workforce in those, those days, like, oh, well, that's really changing their cardiovascular risk. It really had more to do with family and specifically with relationship stress. So, and I think that when we look at chest pain that is related to stress, I've seen that in a lot of my female patients. We know that can be related to vasospasm of the coronary artery. So I really believe that women, even more need to take care of looking at what are the provokers of stress and really how to condition themselves to have a better stress reaction or a better response to stress and a better conditioning for the stress response.
I've read there's a book called The Upside of Stress by McGonigal. Fascinating book. And she characterizes some research that shows that when people simply take the same stressor and call it excitement instead of stress, that alone was protective against a number of adverse health outcomes.
Yeah, I love that. Yeah. I think that you can see that play out for people. One person's interpretation of the same event is, oh, this is exciting. This is an adventure. This is a challenge. And another person's is, oh, OMG. Yeah.
I'm remembering, and some of that's personality, how you're going to take life stressors, but I'm remembering at least one study where people were randomized to
Mhm.
either say, I'm excited," versus "I'm stressed," and so just that language. But besides that, obviously, there's probably more important things we can do to manage stress. What would be your prescription to someone who you think has sort of a lot of stress in their life?
Right. So I think I think it's personal for every person, but I do think some form of mindfulness meditation, some form of, could be spiritual, could be reading. Um, One of the fascinating areas that I have looked into is heart rate variability, which is a kind of an interesting concept to explain. But for many of us, uh, heart rate variability will mean, and I'm going to talk about this, and you're going to see where I'm going to go with it in a second. How does this relate to stress? But heart rate variability for some people might mean, oh, my heart rate in the morning is 50 when I wake up, and boy, in the afternoon, I don't know why it's about 75, so they think that's heart rate variability. Well, yes, that is hour by hour variability. But when we're thinking about this term heart rate variability, it's really the beat by beat 1 to beat 2 to beat 3 to beat 4. And what we know is that when people are not sleeping well, when people are stressed, when people are overtraining, physically overtraining, that their heart rate variability narrows. So you would say, hey, isn't that going to be good? They're just going along exactly the same every beat to beat, but it's not actually. You want that variability. You can think of it as, waxing and waning of that beat. And it's interesting because we used to do a study, and we don't do it, signal averaged EKG. Do you remember that
Vaguely,
ever?
vaguely.
And it's a marker. We used to do this after post MI patients to assess their arrhythmic risk. And signal averaged EKG looked at heart rate variability. And if you had low heart rate variability, you were at more risk for sudden cardiac death. So this was in patients who had, a big MI and a lot of tissue lost. So when you do meditative, not necessarily a guru meditation, but just mindfulness based stress relaxing things, you improve heart rate variability. Lots of science on that. So to me, this is all a conditioning. Not only does it make you feel better, but it actually is a healthier physiologic response. And there are some interesting ways that you can monitor this at home. There's a device called HeartMath where it can measure, heart rate variability. And it was impressive to me when I did this on myself that I could, in the matter of 2 minutes, change that heart rate variability. So it would start as one thing, and then if I applied a relaxation intervention to myself of some nature, I could in real time see the change. And to me, that's just fascinating. It's just the heart brain wiring.
Right. I have one of those as well, a heart math device, and it's fascinating. It's really a matter of slowing your breathing, is
Mhm.
mainly, but it's fascinating how you get that immediate biofeedback that,
Mhm.
that you're optimizing, you're increasing your heart rate variability. I hope that that activity translates to lower risk of heart disease. I guess the
Mhm.
evidence suggests that's the case.
That's right.
Terrific. So we've covered stress to some, I mean, obviously we haven't thoroughly covered any of these topics. We're hitting the highlights here, but stress management. We talked about exercise and diet. We didn't talk so much about some of the other pillars of healthy lifestyle medicine, like sleep. You did mention relationships and relationship stress.
Mhm.
And the other one would be substances, which obviously tobacco is no good. I guess there's alcohol. So any other topics in there we should add to our checklist?
Boy, I'm not seeing them, David. So let me know if you
Well,
do.
So, okay, so sleep, not as much of an impact on
Oh,
heart disease.
yeah. No, absolutely. Sleep is critical. And I would say, there with the exception of sleep apnea, I would say that probably sleep is more disrupted if we're going back to women's lives, for many women, between child needs, um, breastfeeding needs, which might put them more, in getting up in the middle of the night, um, and then hormonal, fluctuations and changes there. Um, Sometimes I think women don't have a chance. I mean, they start out, with getting this sleep disruption when children are little. And then just about that time, their kids become teenagers, and that doesn't make you sleepless. I don't know what does. And then they go through, hormonal changes, and they're getting night, hot flashes and some changes. So
Well,
sleep hygiene and a real attention to that is so important, um, in just lifestyle management for sure.
okay, so that's key. It's far healthier to get 8 hours of sleep a night than to get like 4 or 5, right? As far as
Right.
risk for heart disease.
Yeah. And I'm always impressed that when I, really ask people, go through those pillars, and, that sleep, there's just a lot of people that have a lot of sleep disturbance, and they're suffering with it. And it's just impacting all of their other lifestyle behaviors. Um, and there's so much that can be done in terms of just resetting that, and just doing basic structure, and to get yourself to go to bed at the right time, fall asleep, um, and stay asleep. And there's just a lot of levers that can be pulled to optimize that. But if
Right,
we don't focus on it, it doesn't happen.
right. Get that TV out of the bedroom. Don't lie in bed awake. Don't expose yourself to the blue or bright lights before bed.
Mm-hmm.
Um, yeah, avoid the caffeine. The alcohol is a disruptor of sleep.
Mm-hmm.
Yeah, and we should probably have a separate checklist on just sleep and how vitally important it is. Um, so this is great. This rounds out a pretty good and pretty comprehensive, pretty long checklist. I have 17 items on it right now. Is there anything we didn't talk about, Cate, that you think we should add?
Gosh, David, I really think we covered
That's
covered it all. Yeah.
okay. That's a good. I mean,
I
obviously,
wish I'd had this checklist for all the years I practiced cardiology before I was so focused on lifestyle medicine. I would have just handed this over to my patients.
well, it's a good point you make, because I think what we've tried to capture here is your approach to heart disease, and particularly around prevention.
Mhm.
And it's probably quite in a lot of ways quite distinct from how most of traditional medicine approaches this topic, right? Because most of
Mhm.
traditional medicine doesn't have 17 things on the list. They have statins and some other drugs and the tests, and not so much, do we, and I know that cardiologists are getting much better about this, and doctors are getting better about this, but not as much about the nutrition, not as much about
Yeah.
the exercise, or when we talk about it's lip service,
Mhm.
eat less, exercise more. I check those two boxes right there. Literally, it's often that's the extent of the counseling you get from a cardiologist, for
Mhm.
example, right?
Absolutely. It's oftentimes, I used to say it was the as you're going out the door. It was great to see you, you know, try to eat better, move a little bit more, and I'll see you in 3 months, or I'll see you in 6 months. And of course, patients remembered that. But if you're not more prescriptive than that, and if you don't get into the weeds more, so often I felt like it was just a disservice, because they would come back and say, I know you told me to eat better, but they wouldn't know how,
Mhm.
right? I didn't give them enough to quote unquote bite on.
Mhm.
Um, and so in many ways, they would come back discouraged, because their efforts didn't lead to an improvement in their blood pressure or an improvement in their lipids. And so that sort of, quick counseling, sort of little bit of inspiration, sometimes can just be incredibly, makes people feel shameful, and that they're not doing their part, when in fact they really want to. They really want to, but if you're not giving them some real guidance or some prescriptions and goals and the support that they need, they can't succeed, and then they feel bad about that.
Right. And that's, I guess, the kinds of things we tell them is what, that this is really, really important. And you have the power to really reduce almost to zero your cardiac risk if you make big enough changes. And
Yeah.
here's the kind of changes that it's not just eat in moderation, quote unquote. It's no, here's a list of foods here, and you're taking it to the level of recipes. Here's
Mhm.
recipes, here's ways of cooking. So this is a very different experience that someone's going to get when they go and see Dr. Collings than traditional medicine. And I know we're coming around, but and that's part of the goal with this checklist, is to try to get that message out there. And by the way, we will make this a handout that's suitable for
Mhm.
cardiologists to have on the wall, or hand out to their patients, or patients to
Mhm.
hand to their cardiologist or their
Oh,
doctor.
nice.
Um, so, so we've come a long way. We've put together this great, awesome list that's like, gosh, I wish we could have transport this information back 20, 30 years ago, and I wish we could spread this throughout the world. If this checklist were to be followed by everyone to whom it should apply, what would be the impact?
The impact would be enormous. I mean, when you just think of, you know, 30%, 1 in 3 individuals in the United States has heart disease, right? Or dies from heart disease. 1 in 3 dies from heart disease, I should say. And another 1/3 or more have heart disease, and they just don't know it yet. So, enormous power in this. And, we know, through, regions of the world, the blue zones and so forth, that people who naturally follow this kind of a lifestyle because of the circumstances that they're in and the environment, have a very, very low incidence of heart disease and other chronic diseases. So when we look at it over time, sure, there's going to be sporadic events, but when we look at it at a population level, we just know that we could just dial down this
Mhm.
heart disease in the United States and globally, by dialing up lifestyle and really realizing, that people have so much more in their control.
So as
I
Dr. Go ahead.
Yeah, so I often, when I start, and I'm not a scientist like an epigenetics whiz, but I oftentimes start my talks with really juxtaposing genetics with epigenetics. And because I think it's fascinating, this idea that we can turn on and turn off gene expression,
Mm.
right? The DNA can be there, but we can turn it on, the expression of this genotype or into a phenotype. So, epigenetics, I sort of feel like is the rocket science of lifestyle. And that's why we can look at the same genetic pool and apply the lifestyle and the environment differently and get totally different outcomes. And that's what's happening in, I think, the blue zones and in individuals who follow these principles.
Yeah, I think there's a lot of research that suggests, well, as Dr. Esselstyn says, heart disease is a toothless paper tiger that need not exist. I think I've heard him say that multiple times.
Right, right.
But isn't that a fascinating idea, that the heart disease need not exist? And if everybody were to follow this particular checklist, it would be a lot less common. I'm not going to say zero, but a lot less common. I mean, we're talking about like slashing rates of heart disease, right? Like over 50% if people were to follow this list effectively, right?
Right, right. Yeah, and I think people kind of have come to accept that this is just part of aging, but it doesn't need to be, actually,
No, no. Oh,
Yeah,
I wish we could clone you, Dr. Collings,
right.
and spread you all over the country, because there's so much suffering that happens that really is kind of needless in the end and could have been prevented, could have been avoided if people had the right information and developed the right skills at the right time. Well, I don't want to take any more of your time. This has been a stimulating conversation for me, and I hope for our listeners. We're going to package this in as best we can with as many scientific references that we discussed and alluded to in the conversation, and we'll put it out there for the rest of the world to enjoy. Many, many thanks for taking the time today to spend this with me.
Yeah, absolutely. And thanks to you for doing this and making this available. I think it's great. I love it.
Oh, I love it. This is so fun. So, Dr. Cate Collings, many, many thanks. I wish you all the best. Happy presidency.
That's right. That's right. Okay, David.
Take care.
I'll
Farewell.
see you.
So, wasn't that conversation great? Don't you love Dr. Cate Collings? She is such an effective leader, and yet she is very soft spoken, and I just love that about Dr. Collings. So, at this point, I thought I would do something rather avant-garde. We're going to read you the checklist. So it's been a few days later, and I've had the opportunity to spend some time, research the topic a bit more, kind of craft things into this checklist, and I will now read it for you. So here is the checklist to prevent cardiovascular disease in women. Number 1, regularly measure your blood pressure, blood cholesterol panel, blood glucose measures, including hemoglobin A1C. Work with your doctor or provider to control these numbers. Number 2, a coronary artery calcium scan can help you quantitate the blockage in your coronary arteries. That is to say, the arteries around your heart. It does involve radiation, but this scan is appropriate in people with medium risk for cardiovascular disease who are willing to make the healthier lifestyle changes. Number 3, know the signs of inadequate blood supply to the heart, that is to say, angina. When women have angina or angina, they sometimes have chest pain and sometimes not. Frequently, women have more subtle symptoms like either nausea, shortness of breath, or chest pain. Number 4 is avoid dangerous testing that you don't need. So a stress test is usually only warranted for people with angina symptoms like chest pain or shortness of breath, or some of those other symptoms in a setting where you really have some degree of suspicion of cardiovascular disease. That is to say, people with multiple of our risk factors, high blood pressure, high cholesterol, or diabetes. Stress testing carries risk, especially the nuclear medicine stress testing. It does carry a pretty hefty dose of radiation. Number 5, beware false reassurance from doctors. Male doctors tend to not recognize heart disease in women because the symptoms can be different in men, and also because there's a bit of a bias that heart disease is a man's condition, when we know heart disease is and cardiovascular disease is the number 1 cause of death in women. Number 6, rethink your food. So much of the Western diet that we have and the foods we have been taught to enjoy are bad for our heart and our blood vessels. Shift away from the highly processed foods to more unprocessed foods, and shift away from the animal products to more plant-based foods. Number 7, anti-inflammatory foods are especially beneficial. Leafy greens, dark yellow vegetables, fruit, intact whole grains, spices, herbs, darker foods in general are more of those anti-inflammatories. You want to avoid the pro-inflammatory foods such as red meat and processed meats, and processed foods in general. Eat mostly healthy fats in small quantities. Flax seeds seem to benefit hypertension. A modest amount of nuts are important. Oils are a processed food and are mostly unhealthy, with the possible exception of perhaps extra virgin olive oil in small quantities. Overall, reduce your fat intake, especially the saturated fats and the trans fats. Number 9, monitor your lipids. A low-cost lipid panel is the key test that you want to get. Most important measure on that lipid panel may be your LDL. The goal for LDL is under 100, but if you have other cardiac risks, then your goal is really to get that LDL below 70. Number 10, reduce sodium. Processed foods, fast foods, restaurant foods tend to be quite high in salt. When you eat out, ask for less salt and less fat while you're at it. And ideally, eat at home as much as possible. Number 11, exercise. Super important for the female heart. Women too commonly stop exercising when they get busy with caregiving. I have seen this happen so many times in my life. Women selflessly driving people and not exercising. Number 12, sleep 7 to 9 hours per night. Shoot for about 8. 7 is acceptable. Sleep is critical, and it is commonly disrupted in many women. Healthy sleep habits are super important, especially in women. Some research suggests that acupuncture, mindfulness, reflexology, exercise, and yoga can help women sleep better. Number 13, de-stress. Excitement is good stress, and it can help us thrive, but relationship stress can be especially harmful for a woman's heart. Mindfulness meditation can help a lot. Heart rate variability is an important indicator of stress. You can improve your heart rate variability and your stress level with slowed breathing. Try to take 5 seconds for an inhale and 5 seconds for an exhale. And continue that slowed, calm breathing. And number 14, while you're breathing, breathe clean air. Minimize your exposure to pollution, and in particular the particulates, by avoiding outdoor activity on high pollution days, and perhaps swap out your gas stove. And that is our checklist to prevent cardiovascular disease in women. Thanks for joining us this time, and I look forward to seeing you next time.